Welcome to this webinar, this year-end Reconnect webinar on Hypermobile Ehlers-Danlos Syndrome and Hypermobility Spectrum Disorders by Marco Castori. A quick introduction to this webinar. The webinar will be recorded and then published on the year-end Reconnect website and on our YouTube channel. For any questions during the webinar, you could use the questions and answers session, which is in the black bar in the bottom of the Zoom platform. Or if you prefer, you could use the chat. Then we use these questions to Dr. Castori. After the webinar, you could take a moment to complete our satisfaction survey, which will start automatically after the end of the webinar. And as usual, you could use all our channels for any communications. The email, you could use our website, which is full of info. And of course, you could subscribe to our YouTube channel and to our newsletter in order to be updated on all our initiatives and other webinars. And now I'll give the field to Dr. Castori.
Okay. Good afternoon. Special thanks to Professor Marta Mosca and her staff for this kind invitation. I am a clinical geneticist, so I would apologize for my not specifically rheumatologic terminology. Anyway, I was invited because my leading interest in the last years was joint hypermobility and the Ehlers-Danlos Syndromes from a clinical genetics point of view. I started to see and consequently to work on EDS since 2010 when I was a young clinical geneticist at the San Camillo Forlanini Hospital in Rome. Before I spent 2 years at the ED Institute, which is a dermatological institute in Rome, where I had the great opportunity to see my very first patients with EDS. Since the very first years of my study of Ehlers-Danlos, I slightly moved my focus of interest on joint hypermobility. As probably most of you know, joint hypermobility is a quite common feature in Ehlers-Danlos syndrome. And the literature sometimes manifests some kind of confusion around joint hypermobility and EDS. In some papers, joint hypermobility seems to correspond to EDS, but it is not the case, absolutely not. Joint hypermobility is a neutral term, is a feature that is quite common in humans. And this term stands for the ability that a joint, a group of joints, or multiple joints, sometimes representative of the entire musculoskeletal system, have to move beyond normal limits. In the literature, you can find some terms that often are used as synonyms of joint hypermobility, including joint laxity, double jointedness, and joint hyperlaxity. It's true, joint hypermobility is a leading feature of EDS community, but joint hypermobility is not EDS. A great paper by a Scandinavian group reviewed the literature in 2007 around epidemiology of joint hypermobility. In this paper, the colleagues show that joint hypermobility is 1 point, common in humans, more common in children and females. and presents variability among ethnicities with a tendency to higher frequencies in Latin Americans and Africans people. However, still in this literature review, there was evident that such a variability in frequency, you can see in the slide that in females, joint hypermobility has a frequency from 6 to 57%, and in males from 2 to 35%. Such a variability is also the result of a bias, because the methods of assessment of joint mobility and consequently on attributing the presence or not of joint hypermobility is quite variable among these studies. Anyway, in a clinical setting, we can define joint hypermobility in four rough subphenotypes. Localized joint hypermobility is a form of joint hypermobility that affects a single or a few joints. Sometimes such kind of joint hypermobility is congenital, but it may be equally caused by acquired events such as sport traumas. In this kind of joint hypermobility, the Baton score, we briefly will speak about Baton score in the next slides, is negative. The generalized joint hypermobility is a form of a joint hypermobility that affects multiple joints that are arbitrarily considered representative of the entire musculoskeletal system. In this kind of joint hypermobility, the Baton score is positive. In clinical terms, you can also find two additional types of joint hypermobility. A peripheral joint hypermobility that is a form of joint hypermobility that affect hands and feet. Is a form of generalized joint hypermobility, but large joints are not affected. It's quite common in children. It's quite common in children with neurodevelopmental disorders. Baton score is negative. Lastly, in the past literature around joint hypermobility, and more specifically, the joint hypermobility syndrome, there was an emphasis of historical joint hypermobility. Historical joint hypermobility is a form of joint hypermobility that is present only in the personal history of the patient. When you see the patient at the time of first evaluation, you cannot find joint hypermobility. It's not clear if historical joint hypermobility has a true clinical relevance, but in patients with chronic pain, chronic musculoskeletal pain, the possibility that the individual, the patient, has remember some kind of double jointedness in his or her childhood is not uncommon. But obviously, in historical joint hypermobility, the Baton score is negative. Joint hypermobility is a clinical neutral term, sign, sorry. But it needs a special care by the practitioner, because it's not easy to assess appropriately the presence or not of joint hypermobility. First of all, you need an orthopedic goniometer. Without an orthopedic goniometer, you can overestimate or underestimate the range of motion, and consequently underestimate or overestimate the presence of joint hypermobility. Range of motion ranges of motion are available for most joints in children and adults. There are also websites that offer you the standards. So it's not so difficult to obtain reference values to be used in your office. At the same time, you need to be familiar with a Bayton score. A Bayton score is an easy tool that was defined for the first time in 1973 by Professor Bayton score from South Africa. This score was originally intended as an epidemiological tool to assess the range, the distribution of joint hypermobility in African girls. After its first appearance in the literature, again in 1973, it was subsequently used as a clinical tool for discriminating individuals with or without generalized joint hypermobility. The Bayton score is not applied to a joint, but is applied to the entire body. It's a set of maneuvers, including 9 limb joints and anterior spine bending. The score ranges from 0 to 9. A cutoff of 5 is currently used for the presence of generalized joint hypermobility in adults, and a cutoff of 6 was recently introduced as the cutoff for children. You can see, you can find a complete overview on this issue in the paper by Jul Christensen, again from the Scandinavian region of Europe. At the beginning of the last decades, Alan and Professor Graham published the 5-point questionnaire, which is a rapid 5-point screening for assessing the possible presence of a history of double jointedness in any given patient. Currently, around this tool, there is a debate. We are not completely sure that this 5-point questionnaire can be used, is valid in a clinical setting, but again, these questions can help you when you are interviewing patients with a suspect of joint hypermobility and related disorders. Close to the concept of joint hypermobility, there is also the concept of joint instability. The definition of joint instability is not clear in the literature, at least on my perspective, sorry. In my view, joint instability is something in the middle between, joint hypermobility and clinical manifestations such as joint dislocations. Joint instability can be intended as a pre-pathological condition bridging the gap between joint hypermobility and joint dislocations and other clinical manifestations of joint hypermobility. Joint hypermobility usually doesn't need anything for treating it. But joint instability should be considered also for prevention and treatment plans. And is a form of, it can be intended as a form of joint instability along non-physiological axis for the joint. Anyway, joint instability that is a prelude of clinical manifestations related to ligamentous laxity should be accepted as etiopathogenetically heterogeneous, because Joint instability cannot be intended only as the direct and natural consequence or consequent of joint instability, but might it be the results also of muscle disorders, neurological disorders, and bone disorders, particularly bone dysplasias. So again, in front of joint instability, it's correct to think on joint hypermobility, but your mental flow chart should also include these other possible causes. Joint hypermobility may be clinically relevant, first of all, because it associates with a series of apparently secondary manifestations. The first of all, joint hypermobility may predispose via joint instability to dislocations and predisposition to soft tissues injuries. Also, in the absence of dislocations, joint hypermobility predisposes to recurrent joint microtrauma. And this can lead directly to pain and, for example, degenerative diseases like precocious osteoarthritis, although literature is still preliminary, is still not clear around this point 6, sorry. Pediatric literature is full of references around a possible link between joint hypermobility, muscle weakness, hypotonia, and reduced proprioception. The mechanism underlying this association is not clear, but probably the muscle hypotonia, muscle weakness or hypotonia, is probably the consequence of a reduced proprioception that is intended as a neurological, paraphysiological consequence of joint hypermobility. There is also little evidence around an association between joint hypermobility and a mild reduction in bone mass. But this is tautological, joint hypermobility associated with a series of minor musculoskeletal traits such as scoliosis of mild degree and flexible flat feet. When we think at the joint hypermobility as a clinical, as a phenomenon of clinical relevance, we should have clear in our minds the differences between pathogenesis and pleiotropy. Pathogenesis is what we talked about in the last slide. So the connections between joint hypermobility, that is a common and physiological trait in some terms, and the clinical manifestations that can be considered as the consequence of this trait, such as micro and macro traumas. On the other side of the slide, you can find the term pleiotropy. Pleiotropy is a quite famous term in genetics. Is the ability that a gene, or more specifically, an allelic variant of a gene has to influence the development, so the morphology and the function of two or more structures independently. Pleiotropy is the underlying phenomenon explaining why a patient with a classical EDS has joint hypermobility, skin fragility, mitral valve prolapse, etc., etc. Because the involved gene, or more specifically, the mutation that lead to the phenotype, has to influence the development of the cardiac valve, of the skin texture, and the resiliency of the ligaments. under a slightly different perspective. When we think at pleiotropy, we think at the etiology of the syndrome. A single cause, that is one mutation, determines the development of multiple features involving multiple structures independently. On a pathogenetic perspective, a physical trait such as joint hypermobility can manifest in different ways on the musculoskeletal system, and any single manifestations can be intended as the consequence of a single mechanism, this single trait. This explains how in our clinics recognize that the combination of joint hypermobility, dislocations, and or soft tissues injuries, and or recurrent musculoskeletal pain, etc., is not a syndrome per se, because a genetic syndrome and some things like different from this. This is a pathological combination of features, but is not a syndrome. It's not enough. It is not enough for a syndrome. In genetics terms. Still in genetics, this slide could help you in understanding the concept of syndrome. When you see a patient as an individual with generalized joint hypermobility, you see the presence of a constitutional trait. The evidence that this trait is genetic is the formal segregation of the trait in the family. So I invite you to extend the physical examination also to parents, especially in benign form of generalized joint hypermobility. A similar trait is present in the father or more commonly in the mother. This is an indication, is a clue for a genetic origin, but at the same time may be a clue for a benign form, a non-syndromic or mildly syndromic form of joint hypermobility. When you see generalized joint hypermobility in combination with other structural, for structural I means morphological, phenotypical trait involving other tissues and organs, such as the skin, such as the habitus, you are probably in front of a pleiotropic phenotype, and therefore in front of a possible syndrome. The genetic syndromes with featuring joint hypermobility as are dozens. The first group are surely the hereditary soft connective tissue disorders, and among them Ehlers-Danlos Syndrome, but also, for example, Cudis-Laxe and Marfan syndrome, Loeys-Dietz syndrome. There is also an increasing number of skeletal dysplasias featuring joint hypermobility in its generalized form. The most common one are those associated with mutations in collagen 2 and collagen 11, such as Stickler syndrome. It's quite common also in trichorhinophalangeal syndromes. But you can also have a subset of hereditary myopathies featuring joint hypermobility. In our experience, we have at least 2 cases of hereditary myopathies that were originally ascertained by the clinical geneticist by the presence of joint hypermobility. Still in the field of clinical dysmorphology and clinical genetics, there is a large group of chromosomal, genomic, and monogenic disorders featuring joint hypermobility. And potentially, its secondary musculoskeletal manifestations. A few slides on ADS. I know that the future presentation will have ADS and its nosology as a more complete focus. Anyway, the Ehlers-Danlos Syndromes is a community of syndromes featuring a set of shared manifestations. The most common ones involve the musculoskeletal, the mucocutaneous, and the cardiovascular systems. The joint hypermobility and its secondary manifestations, skin fragility or alterations of the skin texture or scarring defects are quite common. At the same time, minor cardiovascular manifestations such as valve prolapse and dilatation of the ascending aortas. A subgroup of EDS, especially in particular vascular EDS, kyphoscoliotic EDS. Anyway, we can find a good review on vascular manifestations in EDS, an issue of Matrix Biology journal by Professor Malfay in Ghent. Anyway, there is a restricted number of Ehlers-Danlos syndromes, such as vascular EDS and kyphoscoliotic EDS, featuring severe arterial involvement in forms of predisposition to spontaneous ruptures of these vessels, and so an impact on life expectancy. This is another picture that I hope will help you in understanding such a complexity. There is a set in the bottom of this pyramid. There is a set of shared manifestations that probably mirror some convergent pathogenesis, starting from mutations in different genes, and a set of distinctive features that can help the physicians in distinguishing one type from the other in the office due to specific genotype-phenotype correlations. The current classification identifies at least 13 types of EDS. 12 of these 13 types have a known molecular basis, so these 12 types can be confirmed and should be confirmed at the molecular level by molecular testing. The hypermobile EDS is still the unique, apparently Mendelian form of EDS without a known molecular basis. So, in the presence of hypermobile EDS, molecular testing is, by definition, negative. Shortly after the 2017, the publication of the 2017 International Classification, an additional type of EDS was described that is autosomal recessive variant of the classical EDS and is named HABP1 classical-like EDS. Diagnosis hypermobile EDS is possible only by the rigid formal and critical application of the published diagnostic criteria. Again, the diagnosis of hypermobile EDS is a clinical diagnosis. Molecular testing is helpful only for differential diagnosis and for formalizing the respect of criterion 3. The presence of generalized joint hypermobility is necessary for a diagnosis of hypermobile EDS. The current criteria slightly modified the application of the Bayton score as I illustrated you in the slides before. Anyway, in the absence of generalized joint hypermobility, it's not possible to formalize a diagnosis of hypermobile EDS. Criterion 2 needs the presence of at least two among systemic involvement, 1, family history, 2, and specific musculoskeletal manifestation, 3. The systemic involvement is in the absence of a clear family history, you need feature A and feature C. So systemic involvement and musculoskeletal manifestations. Systemic feature A represent the pleiotropic nature of hypermobile EDS. Finally, you need a formal exclusion of partially overlapping conditions, including rheumatological manifestations when pain is the leading clinical sign, the reason of referral, and other EDS when there is the doubt by the expert clinician, and other hereditable disorders featuring joint hypermobility if needed. So molecular testing is increasingly requested also for hypermobile EDS because the differential diagnosis is growing for hypermobile EDS. And there are specific circumstances in which clinical exclusion of, for example, collagen 1 overlap disorder or Ehlers-Danlos syndrome is not always possible. So you need, in this case, molecular testing. After such an overview, you can more simply accept that at present, individuals with joint hypermobility can be classified in 3 major groups. Individual with asymptomatic non-syndromic joint hypermobility. These individuals are healthy. Individual with a recognizable genetic syndrome. Recognizable implies that you need a positive molecular testing or a set of diagnostic criteria to be respected. And you need that this syndrome is recognizable, so is known, currently known. And there is a third group of individuals. These individuals are those that who feature some kind of joint hypermobility and musculoskeletal manifestations, but this individual does not respect the criteria for pleiotropic syndromes. For these individuals, the term hypermobility spectrum disorders has been recently introduced. The concept of hypermobility spectrum disorders stands on 3 concepts. First one, that not all individuals with joint hypermobility and related musculoskeletal symptoms have a syndrome. On the other side, that not all individuals with joint hypermobility syndrome, with joint hypermobility have joint hypermobility related musculoskeletal symptoms. There are people with specific EDS and a formal diagnosis on a molecular level without any musculoskeletal manifestations. Third concept is that hypermobile EDS is likely on one end of a phenotypic continuum starting from isolated non-syndromic joint hypermobility and embracing a wide range of intermediate phenotypes sharing non-specific joint hypermobility and the related musculoskeletal symptoms. Currently, there is not any set of diagnostic criteria for hypermobile spectrum disorder because hypermobility spectrum disorder is currently accepted as a descriptor in the between hypermobile EDS and asymptomatic joint hypermobility. and is used for all individuals featuring joint hypermobility and presenting musculoskeletal manifestations, coherent, quindi coherent with the evidence of joint hypermobility after a formal exclusion, like in hypermobile EDS, of any other partially overlapping conditions. Sorry. In practice, when you see people with clinically relevant joint hypermobility, you can often recognize that these people report other symptoms, other sometimes disabling symptoms involving other tissues and organs. These manifestations does not reflect any structural anomalies. These people come to the clinic after many investigations in other organ and tissues, but without a formal evidence of an organic disorder affecting, for example, the heart, the gut, etc., etc. These are functional symptoms. All of them are quite common in the general populations. Among them, there are postural orthostatic tachycardia and any other minor and dysautonomic traits, in general, orthostatic intolerance, a series of gastrointestinal functional disorders like gastroesophageal reflux disease, the lie of the gastric empty, or gastroparesis, and constipations. Pelvic and bladder disorders, such as hypoactive or hyperactive bladder, and psychological distress. Fatigue is quite common in these individuals. When approaching people with joint hypermobility, thinking at this pyramid could help you in stratifying the approach. In this pyramid, you can find in the bottom the general population, because joint hypermobility is recognized as quite common in the general population. Among individuals with joint hypermobility, not all individuals present clinically relevant joint hypermobility. But among individuals with clinically relevant joint hypermobility, there are those with syndromic joint hypermobility. But not all individuals with syndromic joint hypermobility present a recognizable and therefore testable monogenic syndrome with joint hypermobility. Anyway, clinical discriminators such as the diagnostic criteria, or in broad terms, the concept of hypermobility spectrum disorders, could help you in discriminating between clinically relevant joint hypermobility and syndromic joint hypermobility. When you think of the concept of syndrome in this field, you should think like a clinical geneticist rather than a general practitioner, because in clinical genetics, the syndrome means pleiotropy. And molecular discriminators, in other terms, genetic testing, could help you in separating the individual with hypermobile EDS and other unrecognizable, currently unrecognizable syndromic presentations, and individual with a recognizable syndromes that you can confirm with a genetic test. It's like changing this pyramid. So hypermobility spectrum disorders are somewhere here among the clinically relevant joint hypermobility, and the hypermobile EDS is somewhere here among the syndromic joint hypermobility people. This is the past, when we had a set of criteria for the hypermobile EDS, a set of criteria for hypermobility, joint hypermobility syndrome, and a group of individuals with joint hypermobility, symptomatic joint hypermobility, but not respecting the hypermobile EDS criteria and the joint hypermobility syndrome criteria. While in the present, we have a concentric distribution and stratification of individuals by intending the label of hypermobility spectrum disorder in the bridge between hypermobile EDS and asymptomatic joint hypermobility. This is a table representing what I said in the previous slide. All the articular phenotypes taking part to the spectrum. The spectrum is a broader term that include the asymptomatic joint hypermobility, the hypermobile spectrum disorders, and the hypermobility spectrum disorder, because these three broad phenotypes are intended in a continuous spectrum of phenotypes. This is not so easy. Anyway, is a tentative explanation of such a complexity and an illustration of what we currently don't know of this phenomenon. We recognize that pleiotropy is a key concept separating individual with and without syndromic joint hypermobility, and the pathogenesis is the way to understand the musculoskeletal and extra musculoskeletal manifestations of joint hypermobility. The pathogenesis is a real challenge for the future, because in the future, the treatment pass through a better understanding of the pathogenesis of the articular and extra-articular manifestations of joint hypermobility. I hope that this flowchart could help you in your practice. And this slide also introduced another satellite concept, so the transitional phenotyping in the spectrum, because it's implicit in the spectrum that people can change the diagnosis, the phenotypical label, at least between asymptomatic joint hypermobility and hypermobility spectrum disorder in their life. A transition from hypermobility spectrum disorder to hypermobile EDS is accepted, especially because the current criteria are not satisfactory for children, criteria for EDS. The problem is that hypermobile EDS is still a diagnosis of a rare disease. And in many countries, like in Italy, this diagnosis implies that the disorder is chronic and untreatable. So for this reason, attributing this diagnosis should follow rigorously the application of the current criteria. This is another flowchart that illustrates us the broad scenario of human conditions featuring joint hypermobility, and also illustrates you that there are a wide range of possible tests that can be performed in the suspect of a syndrome. So I suggest to all to refer people to a clinical geneticist when you suspect sometimes that is much more, that is more than a combination of joint hypermobility and musculoskeletal manifestations. This is a real summary of we can do when are in front of a patient with joint hypermobility. People with asymptomatic, non-syndromic joint hypermobility are healthy. Theoretically, these people without musculoskeletal manifestation can still present some comorbidities. In this case, you should refer to the specialist without special comments, perhaps commenting on the possible underlying mechanism, for example, concerning fatigue. People with a generalized joint hypermobility can present fatigue, and fatigue can be the result of a combination of muscle hypotonia, orthostatic intolerance, a gastrointestinal and altered intestinal function due to altered motility, for example. In people with hypermobility spectrum disorders, you need to treat musculoskeletal manifestation. 99% of people with hypermobility spectrum disorders came for chronic or recurrent musculoskeletal manifestations. The approach should be multidisciplinary, because currently there is not any effective treatment for chronicity in hypermobility spectrum disorders. You need a combination of changes in lifestyle, a wise use of drugs, and physical therapy. And again, in the presence of comorbidity, the approach is the same. Hypermobile EDS, people with hypermobile EDS need a similar approach, but in addition, at the moment, you need to refer these people to a tertiary center because they need yearly screening for organic manifestations in other organ and tissues. Many of these manifestations are benign, are not so severe when compared to musculoskeletal manifestations, but at the moment the literature is not clear on the opportunity or not opportunity to perform this periodic follow-up. So this is, I think that is the last slide. The spectrum is a concept, is not a rigid approach to people with joint hypermobility. The spectrum is what is outside monogenic syndrome with joint hypermobility. Is a work in progress explanation for people with joint hypermobility, musculoskeletal manifestations, and perhaps some kind of disability related to these manifestations in order to receive a diagnosis and at the same time avoiding to attribute a diagnosis of a true pleiotropic syndrome to people that present joint hypermobility, a severe musculoskeletal manifestation, but without a true multi-organ morphological, structural involvement. Sorry. And in the future, in the near future, very probably there will be some changes in the criteria defining hypermobile EDS. Probably there will be introduced some kind of criteria or elements for suspecting hypermobility spectrum disorders. But the real world medicine of joint hypermobility will not be impacted significantly. Such a review of the nosology will help clinicians in speaking a more shared language, and so for approaching people with a more standardized methodology. Anyway, I hope that this presentation was useful to you for a better understanding of this concept. Thank you very much.
Thank you very much, Dr. Castori, for this very informative and effective webinar. We are waiting for your questions. If there are any questions to Dr. Castori, I would like to remind you that you could use the questions and answers sessions. We have okay, a very nice presentation. Thank you very much from Cyprian from Romania. And I think there are no questions. So I would like to give some advertising on the next webinars from Reconnect. We have a webinar next week from Professor Giuseppe Turchetti on rare diseases, on health economics and rare diseases on 16 September. But on the same topic of this, the today webinar, we have on 6 October a joint webinar with Professor Francisca Malfè and Professor Sulli on skin manifestations on Ehlers-Danlos. And on the 20th of November, a joint webinar with Vaskern and Dr. Lima Roberts and Professor Francisca Malfè on cardiovascular aspects of EDS. So, thank you very much, Dr. Castori, for your presentation.
Thank you.
Thank you very much for all.
Grazie, Alberto. Thank you.
Thank you. Bye-bye.
Bye.